So nothing bad
Exactly.
happens when you educate women more.
All right. There was a tweet that went viral recently. It said, "We do a terrible job educating women about their bodies." And Jocelyn Fitzgerald is here to unpack that tweet. Thank you so much for coming on. I'm so excited to
Yes.
have you unpack that tweet. Tell me where this is
Yeah.
coming from.
Oh my gosh. Well, thank you for having me, first of all. Hello to everyone. This is my like casual state of
All
existing.
good.
I went to physical therapy myself for my back and hip this morning, so I am like
We will
in team PT, like 100%.
exactly.
But yes, to unpack that tweet, I should have it open in front of me, but since I wrote it,
It
I
was a long
can
one.
tell you what
Yes.
it was about. There's a lot there to talk about that I think I talked about this earlier this week actually in a group of like a midwife postpartum support group, and someone asked me, what is the biggest myth that you wish people knew in your field or related to this issue? And I said the myth that if we educate women and birthing people more about the effects of delivery, both
Yeah.
vaginal and C-section, just the effects of taking your body, making two people, and then having it, or like being having one entity of you and your pregnancy and then splitting into two people, that inevitably comes with changes. Some of
Yeah.
them can be injuries. And this idea that if we consent people properly and counsel them properly about those risks, that it will increase anxiety, or we're doing our patients a disservice by teaching them about these things, that we are
Yeah.
somehow saying don't have kids, or like, or we're making like obstetrics job more difficult. None of that has been shown to be true. Now there's
Yeah.
research that shows it actually decreases the amount of anxiety and unanticipated trauma that women experience
Yeah.
when these things do happen. Educating people more only serves to prepare them. So nothing bad
Exactly.
happens when you educate women more. But there really is this pervasive kind of damage control mentality in
Yeah.
obstetrics. It's like, we'll deal with it if it happens. But the ifs aren't that rare. So we end up doing a ton of damage control where we could have just done some prevention up front.
Well, and I think just, and from my own experience, and full disclosure, and I've been open about I laminated my birth plan. That tells you a little bit about my mindset, like, because I was being helpful, right?
Yeah.
And, you think you understand things. And even coming from that educated standpoint, even coming from a biased data set, in that
Yeah.
I typically, if I'm going to see you as a client, there's going to be something going on. Like, I still thought that that was something that I could have kind of ownership and control. And I share that story because, again, like everything that I knew, I still ended up with leakage. I still ended up with prolapse, still ended up with diastasis recti. They're not necessarily
Yeah.
things to be afraid of or avoid or prevent.
Right.
But hey, these things it's like parenting 101. You lose control the second, you conceive, right? Like
You do.
I think to your point, like just educating and calming that fear before it just pops up out of nowhere. And then I mean, I hear that from so many providers, so many clients. Why didn't
Mhm.
anybody tell me this? Specifically prolapse. Let's dive into that a little bit
Yes.
because you've chatted about that a lot in your tweets. That's a lot of kind of your clinical practice. What are the most common prolapse types that we see? And
Mhm.
then kind of what's the spectrum as far as what women can potentially be exposed to?
Sure. And a lot of the content in my tweets is around how we kind of like hedge around how to describe prolapse. They're like, it's a vaginal bulge, or it's a descent of the pelvic organs. No one like really knows what that means. But everyone's like, don't
No,
say like your vagina is gonna fall out. I'm like, well, that is what's happening.
technically,
And then when
yes,
you
that is
don't
what's
like
happening.
technically that's what's happening. No one ever no people get so uncomfortable when I say it that
Hmm.
way. But I found that until I sort of say it like that, no one really understands what I'm saying or what I mean. I draw pictures, I do all these things. I'm like, Well, your vagina falls out, and it doesn't necessarily fall all the way out, but it can fall a little bit out, or it can fall a lot of bit out. And so that
Yep.
brings us to sort of the spectrum, which is prolapse is graded from staged. I'll say staged. Some people use the word grade. They can kind of be used
You're gonna
interchangeably with the
fail.
right. The proper term is staged from stage 0, which is most of us the day we're born, no prolapse whatsoever, excellent support of the pelvic organs, which I'll review what those are in a second, to stage 4, which is total eversion of the vagina. It's
Like
fallen
out the
all the
door.
way inside out, like
Got it.
totally out, which is obviously a bad situation to be in.
Not
Most
preferred.
not preferred, not preferred. Most patients fall somewhere between the 1, 2, and 3. So 1 is barely anything. 2 is a little bit harder to describe because 2 can be totally asymptomatic or it can be symptomatic. 2 just means that it's within 1 centimeter of the hymen or the vaginal opening, but it can be 1 centimeter above up to 1 centimeter below. So it's basically a
Got a
prolapse that's
ballpark.
right at the opening, and that's when people tend to start to feel it. Feels like a tampon that's falling out because the hymen has all these nerve endings that tell you like something is sitting on me right now. And then stage 3 is when it's beyond 1 centimeter. And those patients tend to be pretty uncomfy. They feel a bulge. It's out most of the time, especially, they wake up in the morning, they stand up, and it kind of comes out. Those
Yep.
patients are lining up to come to see me
Yes.
in my office. So I think that answered the first part of your question. So that's the staging. Was there a second part that I'm now forgetting?
Well, let me dive in a little bit with that.
Yeah.
So one of the questions that I grapple with, and I have a theory, but I'm curious to
Yeah.
to see what you think, is I'll have clients. So I'm trying to figure out how the world can exist where I can have a client that by staging probably has a stage 3. So things are starting to exit. They have no perceptual awareness of this whatsoever, other than they notice some blood on their underwear because maybe their bladder's chafing or something along those lines. So we've got
Yes.
this person, but then we also have the mom that probably has done a little bit too much reading. She's constantly aware of something down there,
Hmm.
and you can check them standing, hanging upside down, like you can check them in every different position. And we're talking barely a 1. How can these two situations coexist in a world?
I cannot wait to hear your theory, first of all.
Okay, great. Go for it.
Those, but you know, I have a feeling those patients are probably very different in their age. I find the patient that has the more than +1 prolapse that doesn't really bother them tends to be a little older, maybe 50s, 60s, even 70s.
Mhm.
You can absolutely correct me if I'm wrong, but vaginas do become less sensitive over time. Our whole bodies do. Like nerve endings change quite a bit. Um, it depends obviously on your pregnancy history, what nerves perhaps were involved, what level of sensation was affected by stretching or crush injuries during the delivery. And then for the patient who's very symptomatic, even with a stage 1, early stage 2 prolapse and constantly sort of feels that sensation, number one, I would never tell someone that sensation's not real, but
Yeah.
I do think a lot of that might come back to even a spasm type issue.
Oh, interesting. Okay.
Um, Someone who feels a tremendous sense of pressure,
Mhm.
I think that there might be a little bit more of just like musculoskeletal nerve change that has occurred from the
Yeah.
delivery. And then sometimes those patients also, this is something that I've heard referred to as like the walnut, someone that has urethral hypermobility, and
Yes.
they have
Yep.
that sort of walnut looking rugation,
Yep.
suburethral tissue that is
Yep.
sitting right by the hymen, but the actual vagina is very well supported. It's just that the
Mhm.
urethra kind of isn't, even if they're not leaking. And
Gotcha.
those skin bulges like touch the hymen, and the hymen like it's
There's
activating it
sensitivity
kind of
there.
all the
Yeah.
time. I think it
Yeah.
really depends on their exam because the staging system doesn't tell the whole story of what your vagina really looks like.
Yep.
And it also doesn't necessarily give you a sense of how wide the vagina is or if there's perineum involved. The PopQ system we use is imperfect. So
Yeah.
I'd have to see the vagina in question to answer
Gotcha. No, that's a good answer.
that.
No, that's a good answer. No, there's a couple things, kind of, and one of them, like you've started to kind of touch on both, which actually makes me feel pretty good about it. But like the one thing that I've noticed, especially in the pandemic, because everybody's here,
Oh,
is
the
just
clenching.
even acknowledging that overactivity of the pelvic floor muscles can be coexisting with pelvic organ prolapse. And
Yes.
in my field, back when I started, with Urogynecology back in,
Yeah.
2001, I think it was, like, you only considered overactivity in the context of pelvic pain and dyspareunia and vaginismus and those sorts of
Yeah.
things. And we've started to consider it far more, I think the last, I would say 5 or so years with stress urinary incontinence. I see that a lot with the athletes I work with. And then
Yeah.
now I'm starting to consider it more with prolapse and thinking about
Oh,
if you feel something falling out, you're going to try and kind of hold that
hold it in.
in.
Of
Yeah.
course.
So
There
I
is
think
research on this now.
there's something to that. And then the other, I think I've been able to relate, and you work some in pain,
Hmm.
to kind of how our brain processes pain over a period of time or processes sensation or things like that. And that part of our body, we it's kind of it's not like your hand. It's not like you know what it looks like, you know what it feels like. You've got a lot of, sensory information about it. That part of our body, it's
Yep.
like peeing, pooping, sex, and childbirth. Like that's a really large spread of
Yeah,
experiences. But I
sure.
do think, especially the moms that don't have that much going on, but they have that constant sensitivity, I do think there's a hyper awareness. Like the brain is like getting like almost protective, hyper guarding, hypersensitized. And those are the
Definitely.
ones that like we kind of almost need to dampen that nervous system.
No
And
question.
thinking about that, it's really been a nice overlay of, yeah, we've got to get these women back to function and pressure, but also we have these nervous systems involved. And that's been fun
Right.
kind of playing with that, basically anywhere between like, a 0 to maybe just pushing up to a stage 3. But
Right.
I don't know. What do you think?
No, I do think there's a lot to that. I had a question recently, like, would you put these patients on an SNRI or gabapentin, something like that, for the sort of nerve
Hmm.
ending situation? I think it's extremely possible that someone hyper aware of their body, and I also myself, like, being a I think most physicians have a little bit of hypochondria and a little bit of obsessive compulsive personality disorder. I mean, if we didn't, we wouldn't be
Right.
surgeons, we wouldn't be in
Exactly.
medicine. And I do think there is a little bit of an element of like
Yeah.
an OCPD hypervigilance that
Yep.
occurs, where those patients, if you distract them with another task, they will will stop fixating and stop
Yeah.
over feeling. I hope that doesn't sound like I'm saying it's in people's heads, because I experience these sensations too, and I can be
It's
distracted from
chemically,
them.
yeah, it's
Yes,
chemically. It's
um,
getting the brain different priorities, and kind of
absolutely.
dampening that system. Yeah, totally,
Yes.
totally.
So for that patient, I mean, I do think that a combination of PT, behavioral techniques,
Yeah,
looking into their sort of anxiety and psych history, those things can be extremely helpful.
yeah.
If they all, often those patients are sort of having catastrophic thoughts, and they want a ton of reassurance, like this is not going to fall out of me, and all these
Right.
other things, so that there's a huge component of that. And they are just such a different patient than the,
Yep,
the lady who
yep.
comes in with a stage 3 prolapse. She's like, I do not want surgery. This does not bother me. Like,
Right. Yeah,
let it go. I
exactly.
just wanted to make sure I wasn't dying. But if you tell me I'm not dying, I can live with this. I'm like,
Yep,
okay,
yep.
whatever you want. Like,
Well, and
it's
that's
fine.
I think that's almost the fun, if you can have fun with this, fun working with this patient population, is there's a really certain kind of portion of it that like, let's see how far we can go. Like, let's
Yeah,
see how much we can dampen, let's see how much we can change your sensitivity to it. And
right.
because I think a lot of women, their first message is, oh, I'm going to need to have surgery. And, or, can I even have more children or things like that? Like it literally
Yeah.
just kind of takes them off the rails of their family planning. But when they get that kind of feeling that they can sort of change and alter that feeling, like I can't put the organ back, like that's definitely not my wheelhouse. That's more your
Sure.
wheelhouse.
You can
But
put it back a little bit though. I do tell people, I'm like, listen, if you're breastfeeding or more immediately postpartum, or you have a stage 2 is like kind of the sweet spot. I'm like, you can get a centimeter or 2 of regression from PT, and that might be all you need to
Yeah.
have these sensations go away. So I do tell them. The stage 3s though, I'm like, I don't know.
Yeah. Yeah. No, those are the tough ones. And it's one of those that I'm like, at least go talk to, and we're really lucky here. We've got great urogynes here locally in DC.
Yeah.
Go talk to somebody, get your questions answered. You don't have to do anything right now,
Yeah.
but at least you have a sense. So,
Yes. I think
so
that's so important.
that brings me kind of to my next question. So when someone's trying to navigate, okay, I think I have prolapse, there's so many options. Like they've got their regular GYN. Sometimes the family care provider pops in. Sometimes there's urology. Sometimes there's urogynecology, colorectal.
Mhm.
How do people figure out where to go? Do they need one person? Do they need multiple people? Like what's a kind of typical path?
Yeah. I'd say if somebody has prolapse, not to toot our own horn, but just vaginal prolapse is coming from the vagina, as long as it's not coming from the rectum,
Mm-hmm.
which I'll clarify. A rectocele, for those listening, I had a patient yesterday who was confused about this. A rectocele is when the rectum bulges underneath the vaginal floor and the bulge is still felt in the vagina. A
Mm-hmm.
rectal prolapse is when the rectum bulges out of the anus.
Yep.
So that is a colorectal surgery problem. Oftentimes we will see those patients together with colorectal surgeons, but that is who sees you for that. But anything that is coming from the vagina, the vaginal orifice itself, can be dealt with by Urogyn. We manage the pessaries, we do the surgeries, we make the PT referrals. I think that you could one-stop shop with us in that sense.
I think so
People
too.
who have very straightforward prolapse and are absolutely not interested in surgery and just have a two-dimensional circular ring pessary, definitely like a general gynecologist who has experience with pessaries, fits them in their office a lot, can troubleshoot them. You could be totally fine in that sense. But when you're getting beyond a simple ring pessary,
Mm-hmm.
I think it's time to come see
To
us because
shift.
this is what we do all day.
Right, right. And when for someone even just they just stumbled across the word pessary, like
Mhm.
what types of things can pessaries be helpful with?
Yes. So pessaries, prolapse, I've mentioned. And the other one is that sometimes they can be helpful for stress urinary incontinence.
Mm-hmm.
It's not the best. The difference between a pessary for prolapse and a pessary for stress incontinence is that a stress incontinence pessary has a knob on the end of it that sits underneath the urethra, almost like a poison pressa if you've ever seen
Yes, I
ads for
use those a
that.
lot. Yep.
Yeah, it's just like a little support under the urethra. I find the ones that have the best chance of helping for stress incontinence, they are rings that are open. They're Milex pink silicone rings. The ring part is very skinny
Mm-hmm.
compared to a ring for prolapse, which is thick and holds the shape of the circle well. The one for stress incontinence is very skinny so that it actually can deform into an
Ah,
oval and fill the vagina and adhere sort of to the walls, and then the knob is right at the end.
right at
And
the
I find that
urethra.
that's
Okay.
much more helpful because it can't spin around the way a circular ring incontinence pessary
Yeah.
can. So if I'm fitting someone just an incontinence pessary, I tend to look for it. It's like this pink silicone Milex incontinence pessary, and it snugs right in there
That's
very
awesome.
nicely.
I have some patients that they're scared about putting something there, or they're worried that
Hmm.
it's going to take a lot of effort. And I've had some too that they go and they try one, they don't go back for a refitting. They just try one and like, oh, it didn't work. Like
Yes.
what's the best case scenario? What should a good pessary fitting look like?
A good pessary fitting, number one, you should have enough time. So patients who come to me and it's an initial consultation and I counsel them about a pessary and they want one. Sometimes it's not an absolute optimal pessary fitting. And I tell patients because I understand the copay for a specialist is a lot. Some of them travel far away to see me. I say, okay, we've diagnosed your prolapse. I'm happy to try like one or two pessaries. We're very experienced with them. Ideally, you won't feel the pessary much once it's in there. You might be aware of it, but your awareness probably will dampen over time once it's in. You should not have pain. Um, but I do tell them if one or two pessaries is not cutting it, and this is turning into like a whole hour-long session, they really
Yeah.
deserve a procedure visit
Yep.
for pessary fitting. And normally that's what happens. You have a special visit just for pessary fitting, for trial and error, so that you can get a properly fitted one. Because I don't think, I agree with you. Patients who just have an ill-fitting pessary jammed in there and sent on their
Yeah.
way, they come to me and they're like, "You need to do surgery on me right now. I had this pessary. It was the most
Right.
horrible thing ever." And I mean, I'm always happy to like operate, but sometimes they are patients that like I just like don't know that you really even need surgery. If you
Right.
had a well-fitted pessary,
Yep.
it might suit your lifestyle much better. It just like I have had patients that came, they're like, "This doctor shoved a cube in me," and they have barely any prolapse. I'm like, "Oh my God,
I
like a
know.
cube pessary? What?"
Yeah,
And
like
so,
we don't need to be doing that. We need
oh
to
my
have
God, I can
a good assessment, a good fitting,
think of
making
nothing
sure
worse.
that you get good follow-up. I think
Yes.
that's incredibly important.
You have
Um,
to be able to follow up to get a
yeah.
pessary. If you don't, it's not appropriate to put a pessary in that patient.
Yeah. No, those I mean, those are but I know it sounds so basic, but those are conversations I have with clients. They're like, "Oh, it didn't work." And I'm like, "Well, yeah, I don't know that that was
Yeah,
necessarily great care," which is I think that's the first thing sometimes we have to screen out is our assumptions that something isn't working. What actually occurred, and did the
hmm,
boxes actually get checked, and was it actually, an experience that they should have had? So, um,
definitely.
I think for me, because I see mostly women who've been to other providers, that's probably the first thing on my checklist is to make sure, okay, what was that experience? I need to understand that to make sure that I can
Yes,
start to find the gaps. So, yeah.
I do a
Talk to
lot of
me.
that too.
Yeah. All right. Talk to me about how kind of what we know, not only in the research, but like what you tell clients as far as, okay, great, you have prolapse. This is what you can and can't do. How has that changed over kind of your career? What we used to tell women, not only with prolapse, but like post-surgically, what they could and could not do versus kind of what we're telling them now and what women are doing who have prolapse or their post-surgery.
Yeah. I try to tailor this to each patient individually. I try to gauge their values, how active they are, what they do for a living. Do they have young children? Do they have grandkids? I mean, what are they sort of doing with their body a little bit? What is
Yeah.
their uh, priority? And, you know, my parting line when they have surgery is this is fresh tissue. Sometimes they do need a sacrocolpexy, they have mesh, sometimes it's a native tissue repair. I tell them we want this to heal properly the first time. The way this
Yes.
works is by the tissue that we just repaired, we need good scar to form to hold this repair in place. So
Yep.
please don't go like blasting the stitches, out of your vagina. I'm like, please
Please
don't
don't.
do that. We will be back here. I also tell them before I sort of get into the activity discussion that no reconstructive surgery lasts forever. I
Right.
mean, this is like in a sense, a vaginal facelift mixed with like a hip replacement, kind of. You know, your hip replacement is not designed to last forever. It's an implant. Often you need a revision after 15 or 20 years. You wouldn't expect a facelift. It doesn't keep your face looking the same forever.
Right.
Aging and time and gravity still exist. You're still using your body. So, we do need to expect some amount of failure, but also do what we can to like protect the repair. So,
Yeah.
in the immediate postpartum period, I tell them, I'm like, anything that would have caused your prolapse to feel worse, to bulge out before
Yep.
we fixed it, please don't maybe do those things so much when you're recovering, right? Because
Yeah.
those things are putting pressure on your
Yep.
vagina. They made your prolapse pop out. So I'm like, okay, heavy squats, heavy lifting. Please listen to your body, use your legs, use your back, but please stay active. And I kind of phrase it as what I'm trying to do is protect the stitches. So can't have sex because it might rub or pull on the stitches. You can't do deep squats or really heavy lifting because it might pull on the stitches. If you do anything that feels like the stitches are pulling, please sort of stop doing it.
Yep.
And I say, like, don't soak in a bathtub. That's a little bit voodoo for like a few weeks. So I'm like, we don't want the stitches to dissolve too soon. Like
Gotcha.
these stitches are what's holding it all together. As soon as they're dissolved, like you can kind of go on. And I just tell them, to have pelvic awareness. Most people have good pelvic awareness because they know what triggered
What
the
brought them
prolapse to
there?
pop out
Yeah.
more. And so just remember those actions and try to mitigate them. I send them off into PT for like core, leg,
Yep.
hip stabilization, things that will help them protect their repair. And
Yep.
they tend to respond to that pretty well. Young women are a little tougher because they often have young children. Like the reason they have
Yes.
prolapse at a young age is usually because they have a connective tissue disorder and they're postpartum or have completed childbearing. So that's really hard. I'm like, oh, please
Yeah.
don't reach down and like sling your 3-year-old over your shoulder when, you're
Yeah.
2 weeks post-op. It's tough,
Yep.
but
Yeah. No, that
we do our
it's
best.
very similar conversations. I think any sort of abdominal surgery, pelvic surgery. So I also see women after they have diastasis recti repair, or I mean, obviously
Mhm.
after C-section.
Yeah,
And that's the thing that the point that you just made about making sure that those stitches have done their job. Make sure that we can't speed up tissue healing. And you don't want to go to all
yeah,
this trouble and blow it out right off the bat,
right.
which I think is so important. But I love having these conversations, even in like a pre-op setting. If I have a client that borderline they could be surgical, I'm like, look, if
Hmm.
we address pressure and look at how you can reduce the pressure, all these things, you're going to potentially increase the shelf life of this, reduce your
Yeah,
revision rate. And that's one thing I have a hard time going back and looking at the papers on revision rate, because I think
yeah,
a lot of them don't necessarily look at and again in PT, it's similar situation, looking at how somebody manages pressure or how they lift or how they do certain
yes,
things. So if you deal with that ahead of time, then you're good to go on the other side. And again, if we can increase the life of that, I'm
yeah,
super excited to see in, 10, 15, 20 years, if we start doing this differently, can we get a longer shelf life on some of these surgeries? Just like with
yes,
hip replacements, like you said, like we're getting a longer shelf life on those too, because the
right,
technology's improved and things
right.
like that as
If
well.
you,
Yeah.
it only makes sense that if you like prehab and
Yep.
post rehab the muscles that support the pressure going to that joint or whatever it is that's recovering,
Yep.
like of course it's gonna scaffold it better when it's
Yeah.
done. If you have better core and back strength and you're not deflecting all the pressure when you bend and lift like right into your pelvis, it
Right.
only makes sense that your prolapse repair might last longer. So
Yeah. Yeah.
I think
That's what
that's
I'm really excited to see. That I mean, and again, like a lot of the population I work with, lifters and CrossFit athletes and runners and things like that, the ones who are getting surgery, they are it's not necessarily off the table to not do those things that they enjoyed, or
yeah,
things that maybe potentially led to how they got in there. So
right.
that for me, I think is I'm excited to see the literature start to reflect a little bit about what we're seeing clinically. But
Yeah.
um,
I look forward to
for
that too. And it protects their back, which as someone who's in
right,
PT for my
right,
back, I'm like, protect your back.
exactly. You have it for your whole life, for absolutely.
I know.
Okay,
God.
for you to wrap up here, like, um, what's the message that we have, that we can have now for our clients who, they're looking at postpartum, they're looking at these changes, like what advice can we give to women who are considering getting pregnant or looking at postpartum, be like, all right, this ain't your grandmother's postpartum, this ain't your grandmother's pregnancy.
Yeah.
What advice can we give them at this point?
I think more than advice is just education that these fields of medicine and rehab exist,
Yeah.
that we women are allowed to expect that their pelvic floor be treated with the same respect as any other body part that sustains an injury.
Yeah.
Just because childbearing is so common and so many of us do it, I don't think there is I know there's no male equivalent of such a predictable injury. Like If there
I
was an
do.
injury that all men would have, like a crush,
We would have fixed
trauma,
this a
tear,
long time
stretch
ago.
injury, yes, like to some part of their body that they all would experience sometime between the ages of like 20 and 40. Like we would have we'd have buildings full of pelvic floor physical therapists,
Yes.
like we'd have so many of them. It would be like such a high demand thing. So
Yeah.
I really like, that's why I do love social media very much. That's why I get pretty spicy. Actually, I was on a call with the American Urogyn Society. I'm on like their patient
Ooh,
outreach committee. I love them so much and they do good work, but they're always talking about like posting things on Facebook. And there's like nothing wrong with that, but I'm like, our
we're not
target
on
demographic,
Facebook.
right, is not like 65-year-olds with stage 3 prolapse are going to
They're on
find us.
Facebook.
Like
Yeah.
they're on Facebook, but also their OBGYN is like looking for prolapse in them
Right.
because that's like the gynecologic problem that happens to women of that age.
Yep.
Our target demographic are like millennial moms. This
Yep.
is like, we're getting ahead of the problem with this population. And for so long, Urogyn really has just been like a salvage specialty. I'm like, I'm so tired of
Mm.
us being a salvage specialty. We've got to tell
Be on
these
the front
people that we
lines.
exist early, and we
Yes.
do have data. I mean, there's still a lot we don't know. There's still a lot that's not perfect. This
Yeah.
is a podcast for another day, but a lot of the treatments we have, the studies, the average age in all the studies is like 59 years old.
Right.
And so
Right.
when like a patient with stress incontinence comes to me at 35 and is like, I want a sling, and I'm like, okay, that's all well and good, but we have sling data in 59-year-olds. We don't have it in 35-year-olds as much. Your complications might be very different, or like the mesh might perform very differently. We just like don't know.
Exactly.
So there's a
Exactly.
lot we
No,
don't
yeah.
know, but
No,
I still want them to come.
I had a client in her 20s with a rectal prolapse repair and she can't find anything. I'm like, you won't. Like you're not going to find this. And something
Yeah,
that sounds very scary to her. I'm like, look, I actually see this as
yeah,
you are our N of one and we're going to see how far we can get with this. So don't
that's
let
right.
when you understand where the data is and just don't think that that's going to be you because there's so much more that we can do now and you're healthy and young and we've got good tissue and this is all good. But to your point, like,
Yeah.
and I think my profession's done a killer job, especially during COVID, to get on TikTok, to get on
Oh my God.
Instagram, to like put the
Amazing.
stuff out there, you
I
know.
say that. I'm like, the PTs are just creaming us. I told them, I was like, you
Yes,
guys,
yes we
I go
are.
on, they have these platforms and whenever they invite me, I say yes, because we don't have these platforms. And I do understand why. I mean, we're, we're so busy. I know you guys are so busy too. Being like an academic doctor is tough sometimes. So I'm like, they built these platforms and they're inviting us on and we need to go because,
Right? Well, and that's
um,
that's the
you
thing
know,
too. Like I think it's also important and I, when I'm talking to clients about their providers, I'm like, I have so much hope because the physicians that are being trained now, the younger physicians, I
yeah,
think are so much better about relating to their clients, about giving them straightforward, updated information. It's not, this is how it always is, and you have a baby, this is the
yeah.
price you pay. And that comes out of physicians' mouths sometimes. And I'm like,
Well,
find a new one. And I mean, we could have a whole
right.
podcast on that, but like
On,
to see our providers coming down and speaking at our level. And I think fortunately my profession is such that we do get to spend a lot of time. It's a little bit easier to kind of get that familiarity. But
true.
I total props to you guys for, even considering that, because I know it from an association perspective, having been in in that
Yeah.
role for myself, I'm like, church and state, but now I'm like, I can say whatever I want.
Yeah. I mean, at some point you just have to.
Yeah.
I,
Yeah.
I took an oath to take care of patients, not to
Yeah.
take care of, a medical system or the
Right.
academic hierarchy, or whatever. And it is like we're doing a disservice by not
Yeah.
doing public health education in a time
And
when
that's
anyone
exactly
has
what
a
it is.
platform and can
That's
run rampant and say
yep.
anything.
Yep. But
So,
it's public health, and I think that's where meeting those clients where they are right now. They are on Twitter, they are on, these
yeah,
social media platforms, and that's where people are getting their medical information. And if you're not there, or if you're complaining about, oh, well, that person's saying that and it's wrong. So guess
yes,
what?
yeah,
Show up. and put the good stuff out there. And that's what you're doing. And I'm so,
Yeah.
it was funny. We were talking earlier. I'm like, we've never met in
Oh,
real life,
as are you.
but I feel like I would just like, you're one of my trusted sources. I'm like, go listen to her stuff. Like,
Oh, thank
definitely check
you.
it out. So and again,
I
pushing
try.
your professional organization. I know how challenging that can be. I appreciate the amount of effort that is involved in trying to bring that system along with you for the ride, because you don't have to do that. And it's
Yeah.
amazing for you to try and do that and bring them along with you. So thank you
Well,
for
thank
doing
you.
that.
I try. Sometimes I'm like, listen to me. But, you
Exactly.
know, millennials are on the rise. You can't blame people who grew up. I mean, we have the privilege of having different tools. I have a privilege of
Yes.
making my name known at a much sort of earlier part of my career due to social media. So you have to be cognizant of where people come from.
Exactly. Exactly. And you have an
So,
updated Instagram handle, which I'm like,
oh
wait, is that
yes,
your?
I know. I changed it a little bit just because it was they were getting mixed up with my Twitter.
Yep. You got to go for
So
consistency. It's all about branding, right?
yeah, it is. So
If you want to find Dr. Fitzgerald, she is JJ Fitzgerald MD on Instagram. She's the same on Twitter. Are you on TikTok?
I have an account. I have not yet produced
I'm
anything. I
I'm
am
there too. I have
working on
only
it.
a certain number of hours in the day.
I know. I'm just doing my best out here, but
By the way, you do surgery and all these other things as well. So.
I know. I was in the OR twice this week. I'm in clinic the other days. I do work for a university. It can be a lot sometimes, but
I I
I'm
bow down
working
to
on
you.
it.
I bow
I
down to
try.
you. Thank you so much for being on. We
You're so
appreciate all you're
welcome.
doing for patients and to be on with us today. Thanks again.
Oh, thank you so much.